Good afternoon. I'd like to welcome everyone to the the Pediatric COVID-19 Vaccination Expert Panel for May 18th, 2021. My name is Donald Moore and I'm with the Virginia Department of Health. I'll briefly cover a few administrative announcements before we begin. The discussion format is 45 minutes of moderator asked questions of the expert panelists and 15 minutes of Q&A from participants using chat. Participants will be muted upon entry. If I hear anything, and I do hear a few people speaking, if you could please just make sure you're muted. You should be muted upon entry. If you have questions, type any questions in the chat. A feedback survey will be emailed to all participants following the webinar. Participants who have joined by telephone, send questions to epr@vdh.virginia.gov. Also, in order to complete the survey, please email the EPR training email. Participants who did not provide an email when you joined the webinar, please type your email address in chat in order to complete the survey. This webinar is being recorded and will be made available online. Your moderator for the afternoon is Dr. Michael Martin, President of the Virginia chapter of the American Academy of Pediatrics. Dr. Martin has 16 years practicing in Northern Virginia and is the sole owner of a small pediatric practice in Tyson's Corner. He has 2 children, ages 11 and 15. His 15-year-old already received his COVID vaccination. Dr. Martin has participated in pediatric vaccine trials as both a site principal investigator and sub-investigator on more than 10 trials, including HPV and meningococcal vaccines. I'll turn it over to Dr. Martin.
Thank you, Donald. I really appreciate your work and VDH in organizing this event and giving us an opportunity to discuss the COVID vaccine in children. And I know that AAP appreciates all the work that VDH has been doing. And so we're extremely appreciative of the long hours and work you've done. And so thanks again. Your time is valuable and I appreciate all of you making the time to be here today. This will be recorded, as Donald has said, for your colleagues who may not be able to attend, and we'll definitely get that out through the chapter as well as through VDH. But I want to introduce you to our panel. Our first panelist is Avula. Probably doesn't need an introduction at this point with weekly emails, and I don't know how many webinars he does on a weekly basis. He's the director of the Richmond and Henrico Health Districts. In January 2021, he was appointed as Virginia's vaccine coordinator with VDH. And coordinate he did. He got us back on track in Virginia in terms of COVID vaccination. Danny is a public health physician specializing in pediatrics and preventative medicine, and he continues to practice clinically as a pediatric hospitalist. He's also a father of 5 kids between the ages of 9 and 20, God bless you. Not surprisingly, the 3 who are eligible have all been eager to get vaccinated as soon as they were able. Our second panelist is Dr. Emily Godbout, and she is a pediatric infectious disease physician, hospital epidemiologist, and lead of the pediatric antimicrobial stewardship activities at the Children's Hospital of Richmond at VCU. She's a mom to a 4-year-old, a 2-year-old, and is expecting identical twins very soon. And for those wondering, yes, she did get the vaccine during her pregnancy. Our third panelist is Joanna Pitts. She's a graduate of Virginia Commonwealth University with a BSN and is a registered nurse currently serving as a consultant for the Virginia Department of Health. She recently became a nationally certified school nurse, which has allowed her the opportunity to advocate for students, their families, and school personnel around the state. Joanna has also been an integral member of the Virginia chapter's School Reopening Task Force. And last but certainly not least is Christy Gray. Christy has over 16 years of experience in public health, with 12 of those with the VDH Division of Immunization, where she now serves as the director. She has a strong passion for immunization and is a parent to a fun-loving 7-year-old. The Virginia chapter and I are grateful to Christy for leading the effort to secure funding to establish Immunize VA, Virginia's Immunization Coalition, and including the AAP early in that process.
Okay.
Thank you, panel, for being here today. So to get us started, I thought we would start with you, Dr. Ovala. As we kick off this panel, I think looking at, there's been a lot of change with numbers in terms of disease rate as well as vaccine rates. If you could kind of start us there and sort of frame that in where strategically VDH is looking to go with COVID vaccine efforts.
Sure. Thanks, Dr. Martin. Thanks, everyone, for being here today. It has been an intense, 4.5, 5 months, as you all know, and have been in the midst of. We are over 7.1 million doses administered here in the Commonwealth, and so much of that has happened because of the efforts of private providers, of large-scale mass vaccination of our health systems. And about 3 weeks ago, we hit a very different phase of this vaccine rollout, right? The lines started getting shorter, and you saw more and more appointments available at pharmacies and at mass vaccination centers. And we really, kind of everywhere outside of Northern Virginia, and then about 2 weeks ago in Northern Virginia, everything turned, where the supply outpaced demand. And over the last couple of weeks, we've clearly had to shift our focus. It's no longer people waiting in line ready to get vaccinated, but us going out to people, figuring out how do you decrease barriers to access, how do you go to where people are and make it as easy as possible to get vaccinated. And that work has been really nuanced. In some situations, it was as easy as going to neighborhood-focused vaccination sites, because people weren't necessarily against getting vaccinated. They just weren't going to figure out the state pre-registration system, or make an appointment a couple of weeks out, or go wait in long lines. And so at this stage, if we can make it really easy, they will go ahead and get vaccinated. Now, there clearly is a segment of our population, at least according to the national data, around 20%, that's kind of dug in and likely will not. But that still means there's a lot of people out there who are willing to be vaccinated, or who want the opportunity to talk it through with somebody they trust, whether that's a family member or a healthcare provider or a faith leader. I think there's a lot of different venues that our work shifts to now, a lot of new strategies that we're shifting to over the last few weeks to get to that segment of the community that hasn't gotten vaccinated for whatever reason. But you all, obviously, as of this past week, have a whole new eligible population to get vaccinated. As you all know, the 12 to 15 approval was given for Pfizer. And really, in just a few days, we've made some good progress there. Over 24,000 people statewide, ages 12 to 15, have been vaccinated since May 12th, or whatever day that went live. And I clearly a lot of opportunity left, and I think you all as pediatricians will be a big part of that. There's also a concurrent effort with schools to do on-site school-based vaccination, just like we've done with flu and some other vaccines in the past. And our hope, like every segment of our population, is to try to get as many people vaccinated as possible. Our goal to get to somewhere between 70 and 80% to reach that herd immunity threshold. We don't know what the magic number is, but based on the transmissibility of COVID, we know it's a lot of people, and it's a lot more than we currently have. So while we've made some good progress, at 7.1 million doses, if you take the president's goal of 70% of the adult population by July 4th with at least one dose, we're pretty close. We're at 64% of the adult population in Virginia. But it does mean we've got to keep pace at somewhere between 10 to 12,000 vaccinations, new vaccinations of adults from here until July 4th. And then we'll have to see. Our numbers for 16 and 17-year-olds have not been as good. We're right about 37% of that population, and they've been eligible the entire time. Our hope is that as we make it easier for vaccine to get into your practices, as we have school-based on-site vaccination that those numbers will increase quickly. And then the same holds true for these 12 to 15-year-olds. So a lot of efforts, again, a shift of the effort from doing these large scale, high throughput vaccinations to smaller scale, mobile pop-up community sites and getting more and more into practices. And we've heard from many of you some of the challenges around that, right? The storage realities for Pfizer, the fact that you managing 1,170 doses, particularly with demand where it is, just doesn't make sense for a lot of practices. And so Stephanie Wewell, who's our state pharmacist, is working to find some regional hubs. We went out last week. We have a lot of interest from independent pharmacies as well as practices who just want smaller dose amounts. And so the ability to order 20 doses or 50 doses at a time should become possible in the next week or so, maybe a little bit longer. But also in concert with your local health departments, you can also order smaller amounts. Some local health departments are able to do that redistribution work so that you don't have to get 100 doses at a time or 1,170 doses at a time. So please get in touch with us if that's a situation you're in, that you want to become an approved CDC provider, but you know you can't manage large amounts of doses of that 1,170, and we'll work with you to figure out how to break that up. And then I think the other pivot that's happened is that because we're at the place we are with supply and demand, for the first 4 months of this, all of our messaging to providers was, you got to use every dose. You got to use it as quickly as you get it. You can't carry inventory into the next week. And that was because the demand was so significant across the Commonwealth. That's clearly not where we're at now. And so a lot of our messaging to providers has changed. And so if you are interested in, again, you can hold a few weeks of inventory. You don't need to use it all in one sitting. And then we'll work with other providers or inventory managers to help get you dose amounts that can realistically be used in your practice. But really, looking forward to the weeks to come as we press into this 12 to 18 population, and some of you see up to 21-year-olds. So, it's a tough group to get to, and so your role, your guidance, you guys asking the question and then being able to direct them to vaccine, whether it be in your practice or at a pharmacy or some other outpost, will be incredibly helpful to our overall efforts. So I want to thank you in advance for that.
Thanks, Danny. As a follow-up to that, one of the questions I know that providers are thinking about being sites is some of the ancillary supplies and needles. And I know, actually, for Fairfax, I know they've expressed that's one of the logistical challenges is getting those materials out as part of this. How does that work for providers? Is that being provided, the different size needles, the 1 inch, the 1.5 inch? Is that going to be part of this?
Yeah, so everybody who has become an enrolled CDC provider gets all of the ancillary supplies along with the vaccine. And so I guess with that being broken up and managed, we'll have to work through that a little bit. I don't know, Christy, if you want to add anything to that, but that shouldn't be a concern for any provider who wants to be delivering vaccine.
Yeah, I would echo what Danny said, and also that gloves and sharps containers aren't part of that ancillary kit. So that is something to consider, but as pediatricians, you likely have a lot of those already. But if that is a concern, definitely reach out to us. We can see if there's any way to get those additional ancillary supplies to you.
Right, thank you. So one of the barriers, and I've been surprised, we've actually, even in the chapter, received questions, concerns from physicians, is still about the safety of the vaccine, and really the process that's occurred. So I don't know if, Christy, you can kind of comment on how this EUU process differed from our normal vaccine process of approval. And does that alter safety, and how would best to counsel families about that process?
Yeah, absolutely. What has been difficult is that there's been a lot of misinformation shared about vaccines and the general concern regarding the pace that the vaccines have come to use in the market under the EUA. I always, when I talk about the safety of this process and these vaccines, I try to emphasize no safety steps have been skipped in the development of these vaccines or their review by public health experts in their use. The vaccine process typically takes longer We all know that, but the reason it takes longer is because the financial risk
You just get Lauren in.
is entirely on the manufacturer in a typical vaccine process. And so the
Technically, yes, but I mean, given the fact that she's been here.
If I can ask folks to mute, I have someone having a conversation that probably doesn't want to be had in the group.
So, I mean, if you guys want to come and grab her, that's per protocol. It's anytime a child in the family is tested.
I'll try to talk louder.
Okay.
And so typically the financial risk is entirely on the manufacturer. So the manufacturer takes longer to go through the different steps and the different phases of bringing a vaccine to market. But in this situation with the COVID-19 vaccines, all the vaccines that are in circulation as part of the program were purchased by the US government. So it removed the financial risk from the manufacturer. And that allowed them to move through the recruit and completion of the trials much more quickly.
Like I said,
than
per protocol,
otherwise
yes, anytime
would
somebody
have.
is tested within
They have also been able to build, for example, the plants and manufacturing vaccines were able to be concurrently done as they were tested. That is not typical in the vaccine process. You are normally going through the clinical trials.
Well, and you guys have my email. Right?
Wait till they end in order
to
to do the next step. And oftentimes funding has to be acquired before the manufacturer can go to that next step. Because that wasn't a barrier here, some of these tests were able to happen concurrently, so that when the vaccines could be shipped immediately once they were approved, rather than once approved, mass production would start. So that's really why we were able to get to the vaccine being available as quickly as it was, different than the typical process. There was no step of the safety review that was skipped. It's just that the typical steps, the length of time and the need to have financial security by the manufacturer was no longer a barrier. I'd also like to make sure that the people that review and make the decisions of whether these vaccines should be approved by the FDA and recommended by the CDC are independent committees. These are not FDA or CDC employees. They are career public health scientists, experienced in the field. And every vaccine that comes to the market in the US are approved through those two committees.
Thanks, Christy. Sorry about that. Just remind folks, if you come into the room, please mute your microphone so that we don't get the background noise. Appreciate it. So one of the things that we're certainly worried about the folks who are on the fence or don't want to vaccinate. There's a group of people that actually want to vaccinate their children early who couldn't get in clinical trials. So we're getting that question, especially the 9 to 11-year-olds. I wondered if you could comment on that. Is that something physicians should think about doing, and how you would counsel those families, Christy?
So right now, the vaccine is not recommended outside of that approved population of 12 years and up. It would not be recommended to vaccinate anybody younger than 12 years of age. We are expecting the data and EUA request for approval for down much younger than that by early fall. So we are only really a few months off from that population.
Okay, great. Thank you. And Danny, if we could take a step back a little bit and about the vaccines themselves. So this is obviously a novel, very different vaccine, the Pfizer vaccine that's approved right now, as well as the Moderna with the mRNA technology. So we are getting questions from families about that. If you could comment a little bit on, how do they work? The other thing, a lot of people do ask, what else is in there? So a lot of families will ask about preservatives, additives, those other elements. Is there anything that we need to know as pediatricians as we're counseling families?
Yeah, I might ask Emily, do you want to chime in? I'm happy to talk about it, but I know you talk about this a lot and really well, really compellingly. So happy to have you give it a shot, and I'll come in behind if there's anything else.
Sure. So y'all can hear me still? All right. So how the way that the mRNA vaccines work, scientific answer is that you have this mRNA sequence that codes for the spike protein of the virus. And this is delivered into the body. And then once that mRNA sequence arrives, your own cells will see that and use that as a blueprint to make an antibody. And then that spike protein will create those antibodies and allow our immune system to, have the ability to fight the virus if they see it again. That's the scientific answer. But the answer that I like to give to kids, because that answer I don't think that they would like, and this is something I heard from another physician, is, all right, so the mRNA vaccine, it doesn't contain any virus. You think of it as an email that is sent to your immune system, and the email shows your body and gives it instructions on how to fight the virus, how to kill it, and then like a Snapchat message, it just disappears. So I think that that's a really good way to sort of explain it to a child or an adolescent. And then a couple other sort of just key points is there is no inactivated virus. There's no live virus. It does not incorporate into your DNA. It never actually even enters the nucleus, which is where our genetic material is kept. And then it's broken down really quickly by the body. So those are just a couple kind of key points that I always like to tell people specifically about the mRNA vaccine. As far as the ingredients go, there's no specific ingredients. I have a list of them somewhere that, I have heard parents be particularly concerned about, specifically in the mRNA vaccines. I'm trying to look for that slide I have right now. And I don't know if anyone else has any comments about the ingredients, but I haven't heard any parents. One thing to note is there's absolutely no aluminum, there's no mercury, and there's no kind of food allergens contained within the mRNA vaccines. And that's a lot of things that a lot of parents will get kind of worked up about, or you'll read about on different blogs. So beyond that, I have not heard any specific concerns about ingredients.
Right. And then why I have you, as we're talking about side
Yeah.
effects, we're obviously, we're moving into a different population, right? We're moving into kids. Is there anything different that we're seeing in terms of side effects with kids? I know there's some reports about syncope being maybe higher in adolescents. Is there anything that providers need to be aware of in the pediatric population that looks differently?
So far, the side effect profile in our adolescents is very similar to our adult patients. Specifically in the Pfizer trial, ages 12 to 15, they found that the side effect profile was consistent with what we saw in patients up to 22 years of age. So by far the most common side effect is going to be pain at the site of the injection. About 91% of participants have reported that in the Pfizer vaccine trial, along with headache, some kind of muscle aches. And I will say that these symptoms seem to be more robust after the second shot, which makes sense, right? Because the first shot, you're sort of just showing your immune system, and then the second shot is your booster. So your immune system is going to react a little bit more, so you might see a little bit more side effect profile. In addition to that, a small percentage of kids may have fever. In the Pfizer vaccine, it was 10% of kids had fever versus 2% in the placebo group. And then a very small percentage of children had lymphadenopathy, less than 1%. And the lymphadenopathy was specifically in the neck and the arm area. But again, it was a very, very small percentage. A couple really important notable things from the Pfizer vaccine trial is that there was absolutely no episodes of anaphylaxis among the adolescent patients. There were no cases of Bell's palsy or any sort of facial paralysis. So really, in short, also in addition to that, a lot of these symptoms that we've talked about, if a child develops those symptoms, they're very short-lived, 1 to 2 days, and then will resolve.
Okay. And please put this to rest. Infertility related to the vaccine, because this is obviously a population that would be worried about having kids someday.
Yeah, for sure. So this is my favorite topic. So there is absolutely no evidence whatsoever to suggest that infertility is a side effect of the mRNA vaccines. The reason why we've heard a lot about this is that there was a rumor that spread like wildfire on social media that the antibodies made to the spike protein could attack a protein in the placenta. And so that protein in the placenta, there are potentially some similarities between that protein and then the mRNA protein, but the similarities are only 4 amino acids, so very, very few. So if we were to go down that road and just pretend if we were to see some type of cross-reactivity, we would anticipate at least 50 to 80 amino acids. So it's very sci-fi, it's very far-fetched. It would be like you as a parent being unable to tell the difference between your child or your patient's head and like a dog's head. You know, so the differences in the protein are very, very different. And then just to go down that road a little bit further, if this was true, women that have had COVID-19 infections, if their antibodies were truly attacking their placenta, we would anticipate that they would have a higher risk of spontaneous loss. We have not seen that. Furthermore, the pregnant women that have received the COVID-19 vaccine, we would anticipate that those women who had received the vaccine would have an increase in spontaneous abortion, and they haven't. And the New England Journal of Medicine just last month published this monster study. I don't know if this many pregnant women have ever been followed for safety data, but it was over 35,000 pregnant women who had received one of the mRNA vaccines. It's the largest report on COVID-19 vaccination in pregnancy. It showed that it was safe, and it showed that the baseline pregnancy loss was essentially the same as what we normally see. So no, the vaccine should not affect fertility.
Great, thanks. And this gets us a little bit into where they're going to be monitoring this. Obviously, it continues to be monitored after these vaccines are given, right?
For sure.
And so, Chrissy, I don't know if you can talk a little bit about what that process looks like, and pediatricians may need to be involved with as well, like other vaccines, in terms of the immediate and really long-term post-vaccine adverse event monitoring that we need to do.
Yeah, sure, no problem. So monitoring vaccine safety, as you all know, is not unique to COVID-19 vaccines. Because vaccines are provided to healthy people to prevent rather than to treat and improve quality of life or to improve the situation, the existing condition, the benefit to risk ratio has to be very high. Not only are there several steps in the development process of vaccines to evaluate safety along the way, but that evaluation continues as long as the vaccines are on the market. So vaccines that we've been giving for years are still watched and evaluated through these same existing processes of surveillance systems that we have in place. There are several that are in place in the US specifically for this intent, and the different systems evaluate the adverse events in diverse ways, in diverse settings, to try to identify any signals that there is a safety issue with a vaccine. So as COVID-19 vaccines are approved for use in the US under the EUA, these vaccines are monitored by these systems, including the Vaccine Adverse Event Reporting System, or VAERS. And this structure of this reporting system has really created the most intensive vaccine safety monitoring effort we have ever done in the US. But this continuous robust safety monitoring helps us ensure that the COVID vaccines are safe and that the benefits of the vaccination continue to outweigh the risks.
Right. And so I'm going to shift a little bit because schools are starting to take this on. So Joanne, I'm gonna look at you because you guys want to take this on at schools, which is fabulous. But how are schools dealing? There's some issues that are coming around with schools doing vaccines. How will schools be handling side effects? And I think it's going to look different at different schools. Can you talk a little bit about what schools are doing in terms of bringing online sites at schools?
Absolutely. Thank you so much for asking. We're excited. I see a bunch of school nurses out there in the group, so I'm thrilled to see such great participation. Schools are just an integral part of the community. We're trusted resources, and so we are excited to be able to bring it to the community level to help out parents and help out families. And so as far as adverse reactions, the one thing schools do well is we have plans in place, which you guys know. So we schools have emergency plans in place to help out with any type of adverse reaction that would happen in the school, whether it be an EpiPen for an allergic reaction, but also when we talk about these school vaccination clinics, they need to be performed during the school day with appropriate school personnel and preferably the schoolhouse staff available. And so we are excited because schools are willing to do this. They're making emergency plans for any adverse reactions. We're also able to reach out to our communities and provide a service to our parents and children as far as educating parents of adverse reactions, speaking about vaccine hesitancy. So we are in a unique position to be able to help out our communities. We also want to help out our communities. We are very excited to see the age requirements lowered. And so we are looking forward to getting kids back in school. So we are providing measures as far as monitoring for adverse reactions, following the guidelines from the Virginia Department of Health. And so we are very blessed to be able to come on board and help you guys out.
And so I would be remiss if I don't mention there's been changes with vaccines with HB 1090, and there's new vaccine requirements that are coming out. So some kids may not have gotten meningitis and some other vaccines in this age group. So I probably go to multiple people on this, but Emily, I guess I'll go to you. In the ID world, can we give this with other vaccines as we're giving meningitis, we're giving HPV, we're giving Tdap in this age group? But what's the final say on this?
Yeah, so a lot of you probably remember the original CDC recommendation, which said to administer the COVID-19 vaccine alone and then not to administer anything else after 14 days. Well, that was early on. That was out of an abundance of caution, and it really wasn't based on any specific safety concern. Since that time, there has now been substantial data that has been collected regarding the safety of COVID-19 vaccine. And then us as pediatricians, we have years and years of experience of administering non-COVID-19 vaccines together. And we've shown that the immunogenicity of those vaccines and the profile, the safety effect profile is really not all that changed when they're administered together. So for all of those reasons, the CDC has recently come out and updated their guidance. And I know that this is supported by the American Academy of Pediatrics, that we no longer have to wait a specific amount of time. You can administer the COVID-19 vaccine at the same time as other vaccinations. And if they're coming to you and they've just received the COVID-19 vaccine, maybe they got it at the pharmacy, but they're due for their meningococcal vaccine or Tdap vaccine or whatever it is, you can administer that vaccine safely. You no longer have to wait that 14-day time period. The only thing I would say is if you're in clinic and you're administering multiple vaccines at a single visit, I would just administer each injection at a different injection site. Go ahead.
I'm sorry. No, please, Emily, please.
The other thing I was going to say is from an adverse reaction or safety profile, another thing that people have asked me is after you've received the vaccine or if you've received several vaccines together, is it okay to give ibuprofen or Tylenol? And it is fine to do that to help alleviate any potential symptoms that or if you're having symptoms. I wouldn't do it prophylactically, but if after the fact someone's having a little fever or a little headache, it is okay to give Tylenol or ibuprofen.
Right. And that gets a little bit into the spacing issue. If a child has tested positive for COVID, has had COVID infection, when in relationship to that can they be vaccinated?
So I would say after a child has fully recovered from their infection and they are out of isolation, it is okay to go ahead and proceed with starting the COVID-19 vaccine series. Again, early on, the CDC really recommended waiting a 90-day time period. And I think the part of the reason for that is because it's very unlikely that you're going to be reinfected with SARS-CoV-2 within that 90-day period, or potentially even a little bit longer. So you're probably going to be protected from your own natural immune response. But, you know, given everything that's going on right now, you know, we really want to get our kids vaccinated. I don't see any reason to wait 90 days, especially since we have plenty of vaccine available in our community. The only time I would recommend waiting 90 days, there are certain scenarios. If you have, you know someone, an adult or a child who had COVID-19 and they received monoclonal antibodies or convalescent plasma, those would be times that I would wait 90 days, and that is recommended by the CDC. And that's really because those medications can modulate your immune response. And so when you're getting that vaccine, you want to make sure you have a really good, robust response. And that's why I would recommend in those specific scenarios waiting 90 days.
Okay. And does that, I mean, I think you're sort of hitting on it for the multi-inflammatories, MIS. For those kids, is there any difference in recommendations in terms of when they receive?
Yeah, so it's very similar in the sense that, you know, the CDC right now is recommending or suggesting waiting 90 days. And I would agree with that. You know, a lot of these kids are getting IVIG, which is going to modulate their immune response. And so you could, you know, you could give it within the 90-day time period. It's not going to be necessarily a safety issue, but we want to make sure that they're having a robust antibody response. And if they've received steroids or IVIG, it could potentially augment or affect that. So for children that have recovered from NISC, I would also, again, consistent with the CDC, recommend waiting 90 days. If you have a parent who's really stressed out and they really want to get their kid vaccinated, I would just remind them that the likelihood of their child getting reinfected within that time period is very, very low. We don't suspect that they would be reinfected with COVID within that 90-day time period.
Okay. And Joanna, schools are taking this on, which is awesome, but obviously some details in there, right? So one of the details is consent. Do parents need to be present for schools to give the vaccine, or even in the pediatrician's office? Can you comment a little bit on what that looks like? Do they need to be present? Can they just sign off on a permission slip? How does that work?
Thank you. Thanks for asking. Yes. If it is a school vaccination clinic, which is held during school hours, then it is, and school staff will be available along with school health staff. Then a parent does not need to be present at that time if they have already received information regarding adverse effects in the vaccine benefits. And then if they sign a permission slip or a consent form, and then the child can be vaccinated in the school setting. Of course, they would be monitored afterwards for at least 15 minutes, if not 30 minutes. But if the vaccine clinic is held after school hours, but held on the school premises, but it's after school hours, then a parent will need to be present. So it's a little bit there. And as far as vaccine clinics themselves, a child must be accompanied by a parent, guardian, or an adult over the age of 18 if it's not a school-based vaccination clinic. And if the parent is with the child, then they can go ahead and sign consents and have the child have the vaccines administered to the child at that time. But if it is an adult who is coming with the child but is not a parent or guardian, they will need to verify that the parent is aware that the child has been brought there to receive the COVID vaccine. And if they are able to verify that the parent is aware and consents to it, then that adult over the age of 18 would be able to sign the consent to have that child vaccinated. If the adult cannot verify, then the vaccine will not be administered to the child. The one thing that parents may want to bring with them is some type of photo ID. It's not required, but it may be helpful, or the adult who comes with the child. But school-based vaccination clinics during school hours, the parent does not need to be present, just needs to have a consent ahead of time. And one thing that I would strongly encourage is to make sure that the school itself has appropriate emergency contact information and health record on that child in case of an adverse reaction.
Okay. Thank you, Jen. So I'm going to shift a little bit again. Danny, I've already seen some questions about this. How are we doing with the vaccines in terms of variants? Is the Pfizer still working? And when might we expect Moderna actually to come on board too for kids?
Yeah, so as far as we can tell, the data that's been pouring in over the last few months shows that our vaccines are still very effective against the variants, which is a relief because right now 72% of the circulating disease in the United States is the UK variant, the B117. About 10% is the Brazilian variant, the P2, and then about 3% the South African variant, the B1351. And at least our best data is around the UK variant and the South African variant, still seeing somewhere between 80 to 90% effectiveness when fully vaccinated. There was actually an interesting preliminary data out of Qatar 2 weeks ago published in the New England Journal that showed really significantly lower efficacy with one dose. So your one dose was somewhere between 20 to 30% effective, but then you jump up to 80+% or 75 to 85% effectiveness with two doses. So this data is constantly being updated. We don't have good data yet on this new Indian variant, and so the CDC continues to monitor that, and we'll put out information as soon as we get it. But so far has been very effective against the variants. And then the other brands, Moderna has been in clinical trials with youth, and they, I think, or either by the end of May, we're going to submit their data for an expanded EUA. Johnson & Johnson just started their pediatric trials in April, so I think it's going to be 3 to 4 months at best before that might be an option for this population.
Great. And for our younger crew, do you have any inside information when we might expect for the younger folks under 12?
Yeah, well, I mean, I think everything we've been hearing is what you've been hearing. Sometime by the end of the year, there have been some reports that Pfizer's down to age 2, that their clinical trials are wrapping up. So I think, there's going to be a desire and a push to try to do this either before the beginning of the school year. I think that's probably a stretch. So I would guess best case scenario is probably September, October-ish. But what we're hearing is likely before the end of the year.
Great. And this can be Joanna or you, Danny, or Christy. Schools, there's been questions whether schools are going to require this for sports participation, for entry into school. Are any of you aware of, along those lines, if we expect that there's going to be requirements regarding COVID vaccine?
Question comes up every day, and I think it's a non-starter at the state level while this is still under an EUA. So I don't see it even being possible to be a requirement until it's got its biologics license from the FDA. That requires at least 6 months of data. So I think it's possible. I think the General Assembly ultimately has to weigh in and make that decision, and probably not a conversation for this calendar year.
Okay. And I guess as part of this whole tracking thing with the vaccines coming out in schools, will schools, Joanna, be doing anything different with their own monitoring of side effects? In terms of if there are events at the school and the VSafe program, is that still pushed to the families to monitor?
Well, we always encourage any adverse reaction that happens at the school setting. We always encourage the parents to be notified immediately, and we refer to the healthcare provider, their healthcare provider. So I am certain that school nurses will be tracking as far as adverse reactions for any families. We would, like I said, encourage the parents to be notified immediately and for them to follow up with their healthcare provider. But emergency plans and response are, being carried out. They are already in place in schools. And so we encourage, families to reach out to their healthcare providers. Any adverse reaction that was questionable as far as escalation, of course, we would definitely call EMS. We would and have care brought to the child there at the school setting. So yes, we are on top of the adverse reactions. We just feel that it's best that the parent and the healthcare provider, and of course, we would reach out with our local health department.
So I'm going to shift a little bit to, we have lots of questions in the chat that we've been receiving as well. And I just want to make sure we have time for our folks as we kind of round the bit for the last 15 minutes. So one of the questions that came up, and I guess, Emily, this will go to you, because you talked about what you can and can't do when you get the COVID vaccine and what you can give with it. Can you give tuberculin skin tests with COVID vaccine?
Yeah, I don't see why there would be a contraindication to giving the tuberculin skin test along with it. There's nothing that would suggest at this point in time that there would be any issue.
And a follow-up to that, there were specific questions about if you have kids on daily steroids, sometimes for asthmatics, we're doing that. We have kids on immunoglobulin too, like Humira. Are those situations also contraindications?
So the CDC has recommended, if you have someone who's on a very high dose of steroid or on an immune modulating agent, it would be best if you could give the vaccine and sort of wait a period of time, 2 weeks or something before restarting. But if that's unavoidable, which it is in a lot of these situations, it's difficult to stop those medications, then to go ahead and proceed with the COVID-19 vaccine. Because if these kids are really immunosuppressed, these are potentially a subpopulation of pediatric patients that we're worried about, even more so if they were to contract COVID-19. So this question has come up at Shore at VCU because we have a lot of these kids, but we've sort of followed with the CDC. If we're able to time it in a way before they're started on some of these things, we'll try to get it in. But if not, we proceed with giving it.
So I've seen a few questions related to this, and I think it's been kind of, I've pushed it to the side a little bit. It's about, we're going to be dealing with families who are vaccine hesitant. They're looking for reasons why they should give it. So there's a few things embedded in this. So one is that thankfully we haven't seen the seriousness or the degree of number of cases of seriousness in kids with COVID. And so many parents are asking pediatricians, why should I bother when the risk of the disease itself looks to be so low? I'm going to kind of open this to everyone. I think everyone probably has a take on this. What would you suggest pediatricians say to these families?
Emily, do you want to lead with the MSIC or serious consequence work, and then I can talk more about just sort of the individual versus communal?
Yeah, I mean, I think when we think about our children, one of the silver linings for me in the COVID-19 pandemic is that our children have, in comparison to adults, much less likely to have severe disease, much less likely to be hospitalized, much less likely to have complications. That being said, there are certain children, within that subset that are really immunocompromised and that we need to try to protect. And then some of our children, although a small number, have had really serious infections, been admitted to the hospital, had serious complications. And then some of our children that are otherwise well have had this multi-system inflammatory syndrome, albeit rare. We have seen it in otherwise healthy children. They'll come in really, really sick. We have medications and we know what to do, so their outcome is that they usually end up doing really well, but there is a lot to consider there. Another thing I like to tell people is that it's not just on the individual level, but we think about protecting our community as well. You know, when you vaccinate your child, you're not only protecting your child, but you're protecting your other children, you know, yourself, your parents, and members of your community. And within your community, there can be really vulnerable people. I heard this one analogy about herd immunity, and a way to describe it to children is to imagine a forest full of trees, and you apply a flame retardant only to a couple trees, and then a forest fire comes, aka the COVID-19 pandemic. Most of the trees, you know, in that forest will burn down. But if you apply flame retardant to more of the trees and a lot of the trees within that forest, you're actually going to protect more of the forest. I know it's kind of a crazy analogy, but it's another thing that I think some of our children and our parents can understand a little bit better, is that you're vaccinating your child to protect your child, but also to protect your community as well.
Yeah, maybe the only thing I would add to that is that, you know, there's the medical reason that Emily just outlined. I think there are practical reasons for kids. The reality that if you're fully vaccinated and you're in school or you're playing high school sports and you're exposed to COVID, you no longer need to quarantine. And so that's a huge plus for sports teams, for people who don't want to have to deal with the logistics of switching back and forth between in-person and virtual learning. So I think there are really good practical reasons to encourage kids to get vaccinated around. And then kind of the last part of what Emily was saying, sort of this imperative that we have not just to protect ourselves individually, but really to allow society to move forward as a whole. And what we saw, I don't know, 5 or 6 weeks ago in Minnesota and Michigan was young people really driving the outbreak, you know, high school students, college students, young 20s who were not vaccinated. And so their behaviors led to more interaction, but that led to the highest rates of hospitalization in 30 and 40-year-olds they'd seen at any point. And so I think remembering that the behaviors of younger people often can trigger outbreaks and drive disease spread in communities. And so this is an opportunity not only to protect yourself, but to protect your entire community.
I wanted to add one more thing now that Danny was just talking, is that a lot of vaccines that we give children, a lot of those infections that we're preventing don't always necessarily cause really severe disease in the children. You know, like measles, all of my colleagues had measles, my older and much wiser colleagues, you know, but there's a small percentage of the population that can have a lot of complications from measles. Your kid can also be out of school for a period of time. So all those other things. And so that's, you know, part of the reasoning behind some of these vaccinations, varicella, measles, where most kids are going to be fine, but there's going to be some kids that aren't going to be fine, and that we don't want to propagate it within our community.
Well said. And I'm going to do a senseless plug for the chapter, but we will be putting out, we do have a website with social media posts that you can use on your own websites just to promote the vaccine and some of these things, like Danny said. I know sports is a huge one, that whole teams have had to been quarantined, and that's like devastating to some of these kids. But there's lots of reasons like that that are very practical, that we have those resources for you as well. And I know VDH is putting together some things as well. So appreciate that. Just looking over questions here again. So I guess another question that did come up, I think, in the post as well. Testing, should vaccination affect test results? Some people are asking that question. I know the answer, but I want to make sure everyone is on the same page with this. So we have rapid antigen tests, we have PCR, and we have antibody tests. When you get vaccinated, does that change any of those results? And I don't know, Emily, this is probably as much for you than anyone.
So getting the vaccine will not alter or change your rapid antigen test or your PCR test, but it does have the ability to change your antibody test. There are different antibody tests out there, but I think most commercial antibody tests are looking for the spike protein. So if your patient or your child has received the mRNA vaccine, I would anticipate that they would have a positive antibody response. For how long that will last, you know, we still don't really know. I saw another question in the chat about boosters and will we need boosters? And I think most of us believe that there probably will be a booster. The studies so far have shown that Pfizer and Moderna are probably effective for 6 to 12 months. And then after that time period, we might be looking into sort of an annual booster. But yes, it could augment the antibody response, but not the PCR or rapid antigen.
Okay. And the other thing about it, and this one question that we do get from time to time, and I'll open this to all of you, questions about, part of the concern with the vaccine certainly is that we haven't followed it for a very long period in the order of years. And so the question comes up, how do we really know that 2 years from now, we're not going to see something different, and that's putting those kids at risk that we're giving. So I think part of that's when do we usually typically see side effects from vaccines, and how concerned should we be about really long-term years later?
I don't know if this one is for me, but I can answer it. Historically, over 99% of adverse reactions that we see linked to a vaccine typically occur within the first 90 days. The other small percentage of that, within the first 30 days, sorry. The other small percentage of that will be like an additional 30 days, so within 60 days. And that includes things like Bell's palsy and some of those types of things. So really, and that's what we have seen with vaccines in the past. I'll turn it over to someone else, but it's unlikely, that we're really going to see a really serious adverse event outside of that sort of 60-day time period.
Nothing to add to that. That's great.
Okay, great.
It'll be monitored. I mean, we'll still monitor for these things, but it would be unlikely.
Yeah, I see Christy nodding. She's been in the business for 16 years, so she's sure. Thanks. Another question's coming up, and this may be a little more for Joanna with schools. As we vaccinate kids, are we going to see changes? Are we anticipating changes in mask requirements as we are in adults? That's a hot topic right now, mask wearing.
That is a very hot topic right now. Currently kids, the executive order says, 72 says that children need to have masks on in school, along with staff need to have masks on in school, and teachers need to have masks on in school. And so we are encouraging everyone to, wear a mask. If we learned one thing throughout this was that everyone was wearing a mask and flu season was much lower, if not non-existent. So we know the benefits of wearing one, and so we encourage everyone, and the CDC is still encouraging folks to wear a mask when they're in the school setting. So as of right now, I can go with what the current guidance is. Hopefully, as more folks are vaccinated, more kids are vaccinated, the CDC will change their recommendation more to in line of what we see in our community now with older vaccinated folks. But right now in the school setting, we're all going to be wearing masks and be happy to do it, and encouraging folks to do it.
Great, thank you.
Maybe I'll add that these decisions will be made at the local school system level. And so here's a great opportunity for pediatricians, either if you're already plugged into your school health advisory board, or I think this is it's a great opportunity for advocacy and to just provide expertise to your school systems as they are making these decisions. I do not think there will be, at least while this is under an EUA, that there will be blanket directives that are given at the DOE level around how this is handled. And I think last week's news of the CDC digesting the data and saying vaccinated people aren't at high risk and therefore do not need to be vaccinated. I think as we have more and more kids vaccinated, that'll shift thinking around this at the system by system level. So really important conversations and a great place for pediatricians to lend their voice.
It's like I feel like I just planted that, but that's perfect. I mean, so the chapter, we have a school reopening task force. If you need help doing that, we really are encouraging at the local level people do that. Please reach out to myself and the chapter. We can help you with resources, advise, and do all that, because we do want, we're all involved. I know I've been involved with Fairfax County, and a lot of us have been playing roles working with superintendents as well as the school boards in making their plans. So I would really encourage folks to do that. One last thing as we close up, I do want to make sure this is really clear to people. There's an ask for, and I don't know if Christy, you want to comment this, about parental permission forms if the parent is not present for administration. I don't know if you can comment on if there's a specific form that needs to be, can that be done in lieu of the parent being present? I just want to make sure pediatricians are clear on that.
Sure. So VDH makes policy for VDH clinics. What a private provider pharmacy does is under your typical process anyway. So with VDH, if we're doing a school-based clinic, like prior ones, we send permission slips home ahead of time, and the permission slips come in and you vaccinate those people those children that we had the permission slips for. If the child is being vaccinated in a VDH clinic outside of a school setting, then the person that is accompanying the child, parent, guardian, somebody standing in loco parentis, is providing that informed consent.
Right. Well, that's a close, guys. I want to thank first our panelists for making the time to be on the spot and deal with my spontaneity. Sorry about that. I moved around a little bit, but I appreciate your flexibility with that and making the time and dedicating your work to this. There are some CDC resources that have been updated and created to address adolescents. As I mentioned, the AP has a back to school landing page that I will send out to those of you who attended and get that out to you as well. And these are all listed on this page that Donald has put up. And again, I want to thank you for making the time out of your lunch that, who knows, pediatricians, we don't get lunches, right? I really appreciate you making the time out to be here today to get up to date on this stuff and spend time with us. And I'm going to turn it over to Donald to close us off.
Thank you, Dr. Martin. We'll send out the slides for everyone that signed in with your email address, and we'll also have that available for you, and along with a short survey. URL will be sent to you via email. Ask for your feedback, how this is, and some other things you'll see in the survey. And that concludes this, and thanks to our expert panel and Dr. Martin. Have a good day.
Thanks, everyone.